Part 3. Gaba receptor agonists. A seizure reflects an imbalance between excitatory and inhibitory activity in the brain, with an increment of excitation over inhibition. The most important inhibitory neurotransmitter in the brain is gamma-aminobutyric acid, GABA. GABA-A receptors have multiple binding sites for benzodiazepines, barbiturates, and other substances, e.g., pecrotoxins, bicuculin, and neurosteroids. These drugs bind to different receptor sites to exert their action, but the clinical implications of each receptor site are not well understood. The benzodiazepines most commonly used for treatment of epilepsy are lorazepam, diazepam, clonazepam, and clobazam. The first two drugs are used mainly for emergency treatment of seizures because of their quick onset of action, availability in intravenous IV forms, and strong anticonvulsant effects. Their use for long-term treatment is limited because of the development of tolerance. The two barbiturates mostly commonly used in the treatment of epilepsy are phenobarbital, PHB, and primidone. They bind to a barbiturate binding site of the benzodiazepine receptor to affect the duration of chloride channel opening. They have been used widely throughout the world. They are very potent anticonvulsants, but they have significant adverse effects that limit their use. With the development of new drugs, the barbiturates now are used as second-line drugs for the treatment of chronic seizures. 1. Clobazam. Clobazam has a 1,5 substitution instead of the usual one, 4-diazepine. This change results in an 80% reduction in its anxiolytic activity and a tenfold decrease in its sedative effects. It has been licensed in Europe since 1975, but is not available in the United States. In addition to its agonist action at the GABA-A receptor, clobazam may affect voltage-sensitive conductance of calcium ions and the function of sodium channels. Clobazam is relatively insoluble in water. Therefore, no IV or intramuscular IM preparations are available. Its oral bioavailability is about 90%. Time to peak plasma concentration, Tmax, is 1 dose. 4 hours. The absorption rate is decreased when clobazam is taken with meals, but total absorption is not affected. Plasma protein binding of clobazam is approximately 83%, with the proportion of bound to unbound drug independent of clobazam concentration. Very low plasma protein levels are associated with increases in the unbound, free fraction, for example, in renal or hepatic disease. Brain and saliva concentrations are proportional to the unbound fraction. A good correlation exists between dosage and plasma levels. Significant inter-individual variations exist. Clobazam is metabolized by oxidation in the liver to norclobazam and desmethylclobazam. This metabolite has a very long half-life, 50H, but it has a low affinity for the benzodiazepine receptor, and its anti-epileptic effect is unclear. The elimination half-life usually is in the range of 10-50 hours. Norclobazam is conjugated in the liver and excreted in the bile as glucuronate and in the urine as sulfate. The clobazam plasma level is 350 ng/L. Norclobazam levels typically are 10 times higher than clobazam levels at usual clinical dosage. No significant clinical interactions are reported for clobazam. Minor interactions are common. Clobazam is a potent anticonvulsant for partial epilepsy. No double-blind controlled studies have been reported, but the trials performed showed a striking benefit. In one study, the mean reduction of seizures was 50% in more than 50% of patients. These patients had partial epilepsy and were taking other anti-epileptic drugs, AEDs. In one Canadian study in drug-naive children, clobazam monotherapy was found to be as effective as CBZ or PHT. The major clinical problem with clobazam is the development of tolerance. Sedation tolerance is more evident than anti-epileptic tolerance. No clear correlation between plasma levels and seizure control has been found. No measures have been effective against the development of tolerance. The anxiolytic effect, mild, may be beneficial for some patients. Clobazam is effective in a wide range of epilepsies and should be considered as adjunctive therapy. It can be used in patients with Lennox-Gastaut syndrome or primary or secondarily generalized seizures. Clobazam is administered orally at a dose 10 20 mgd taken at night or twice daily. No parenteral preparations are available. Essentially, the adverse effects of clobazam are similar to those of other benzodiazepines. The most common effect is sedation. Other adverse effects include dizziness, ataxia, blurred vision, diplopia, irritability, depression, muscle fatigue, and weakness. Idiosyncratic reactions are very rare, and no fatal reactions have been reported so far. Clobazam is useful in intermittent treatments, e.g., catamenial epilepsy, and as prophylaxis for some situations, such as traveling, celebrations, and other occasions. 2. Clonazepam. Clonazepam, a 1,4-substituted benzodiazepine, was one of the first benzodiazepines to be used for epilepsy. It is employed in the treatment of all types of myoclonus and is useful in patients with concomitant anxiety disorder. Clonazepam has higher affinity for the Gaba A receptor site than diazepam and binds to Gaba A receptors that do not bind with other benzodiazepines. It may have some action on sodium channel conductance. Clonazepam has an oral bioavailability of 80%. Tmax is 4 hours, but it could be delayed for as long as 8 hours. Plasma protein binding is 86% with a volume of distribution of 1.5, 4.4 L-kilcoag. It is highly lipid soluble and can cross the blood-brain barrier rapidly. Plasma levels and antiepileptic effects are not correlated. Clonazepam is acetylated in the liver. Therefore, the metabolic rate depends on the genetic acetylator function. The metabolites of clonazepam have no clinical relevance. The drug has an elimination half-life ranging from 20 to 80 hours, and it has a very low clearance, approximately 100 ml min in adults. Less than 0.5% is excreted in the urine. Clonazepam levels are decreased by co-administration of enzyme-inducing drugs. No significant clinical interactions have been reported. Clonazepam is a potent AED and the drug of choice for myoclonic seizures and subcortical myoclonus. It is also effective in generalized convulsions and, to a lesser extent, in partial epilepsies. It rarely is used as adjunctive treatment of refractory epilepsy because of its sedative effect and tolerance, which are similar to those of other benzodiazepines. It is very effective in the emergency treatment of status epilepticus, like diazepam, and can be given IV or rectally. Withdrawal from clonazepam may induce status epilepticus or exacerbation of seizures. Psychiatric withdrawal also may occur, manifested as insomnia, anxiety, psychosis, and tremor. Clonazepam is available as 0.5 milligrams, 1 milligram, and 2 milligrams tablets and as an IV solution. The usual starting dosage is 0.25, 4 mg/d once or twice daily. Slow titration is recommended. Clonazepam's major adverse effect is sedation, even at low doses. Children tolerate this medication much better than adults do. Therefore, pediatricians use it most often. Clonazepam has the typical adverse effects of benzodiazepines, e.g., ataxia, hyperactivity, restlessness, irritability, depression, cardiovascular or respiratory depression. Children and infants may have hypersalivation. Occasionally, tonic seizures may be exacerbated. Idiosyncratic reactions are rare and include marked leukopenia. 3. Midazolam intranasal. Midazolam intranasal is a very short-acting, water-soluble imidazobenzodiazepine. Solubility of midazolam is accomplished by the presence of an imidazole ring fused at positions 1 and 2 of the benzodiazepine nucleus, which replaces the ketone at position 2 of the nucleus. The imidazole ring allows midazolam to readily form salts, which have increased aqueous solubility and stability compared with other benzodiazepines. The exact mechanism of action for midazolam is not fully understood, but it is thought to involve potentiation of GABAergic neurotransmission resulting from binding at the benzodiazepine site of the Gaba A receptor. Midazolam is primarily metabolized by the liver and intestinal CYP3A4 to its pharmacologic active metabolite, 1-hydroxymidazolam, also termed alpha-hydroxymidazolam, which is at least as potent as the parent compound. Midazolam intranasal is indicated for acute treatment of intermittent stereotypic episodes of frequent seizure activity, i.e., seizure clusters, acute repetitive seizures, that are distinct from a patient's usual seizure pattern in adults and children aged 12 years or older with epilepsy. Approval was based on the Artemis 1 clinical trial, in equal sign 262, patients randomized to treatment, 201 treated a seizure cluster with double-blind study drug, N equal sign 134 Midazolam intranasal, N equal sign 67 placebo, and were included in the modified intent-to-treat population. 40. The proportion of subjects with treatment success was significantly greater in those treated with midazolam intranasal, 53.7%, compared with placebo, 34.4%, p equal sign 0.109. The proportion of subjects with recurrence of seizures from 10 minutes to 4 hours after study drug administration was significantly lower with midazolam intranasal, 38.1%, compared with placebo, 59.7%, p equal sign 0.043. For diazepam intranasal. Diazepam intranasal is indicated for acute treatment of intermittent stereotypic episodes of frequent seizure activity, i.e., seizure clusters, acute repetitive seizures, that are distinct from the usual seizure pattern in patients with epilepsy who are 6 years or older. As with other benzodiazepines, the mechanism of action is thought to potentiate GABA neurotransmission by binding to the GABA-A receptor. Diazepam is primarily metabolized by CYP3, A4, and CYP2C19. Diazepam intranasal is metabolized to an active metabolite, desmethyldiazepam. The drug has a half-life of nearly 50 hours, including its active metabolite. The dose is dependent upon the age and weight of the individual. It is administered as a single dose with an option to repeat once after 4 hours if needed. Efficacy for approval by the U.S. Food and Drug Administration was based on the relative bioavailability of the nasal spray compared with that of diazepam rectal gel in healthy adults. Diazepam systemic exposure was measured by pharmacokinetic parameters, i.e., peak plasma concentration, Cmax, area under the curve, AUC. The diazepam pharmacokinetic parameters for diazepam intranasal were 2 to 4-fold less variable than those for diazepam rectal gel. In an open-label Phase 3 trial, N equal sign 121, 1,585 seizure episodes were treated with diazepam intranasal in patients with frequent breakthrough seizures or acute repetitive seizures. A single dose was sufficient to achieve seizure control in 92%. 1,457 of seizure episodes. 5. Phenobarbital. Phenobarbital, PHB, is the most commonly prescribed AED of the 20th century. It is a very potent anticonvulsant with a broad spectrum of action. Currently, its use is limited because of its adverse effects. It is a free acid, relatively insoluble in water. The sodium salt is soluble in water but unstable in solution. It has a direct action on GABA-A receptors by binding to the barbiturate binding site that prolongs the duration of chloride channel opening. It also reduces sodium and potassium conductance and calcium influx and depresses glutamate excitability. PHB is a powerful inducer of the hepatic microsomal enzymes. It has an oral or IM bioavailability of 80 to 100% in adults. Time to peak plasma level is 3 hours, but it may be delayed after oral administration in patients with poor gastrointestinal GI motility. The serum peak levels after IM injection are achieved in 4 hours. Ethanol increases the rate of PHB absorption. It is absorbed mainly in the small intestine. Plasma protein binding is 40 to 60%. The concentration in breast milk is approximately 40% of the serum concentration. The volume of distribution ranges from 0.4 to 0.75 Lco. A change in pH causes a shift of the drug between compartments. Therefore, acidosis increases the concentration of PHB in the tissue compartment. After IV administration, PHB is distributed quickly to highly vascular organs, except the brain, and then it is distributed evenly. After 6-12 minutes, it penetrates the brain. But the brain penetration is much faster during status epilepticus because of increased blood flow and acidosis. PHB has a very long elimination half-life, 75 to 120 H. In infants, the half-life is much longer, up to 400 hours. In individuals older than 6 months, the half-life falls to 75 hours. PHB is metabolized in the liver. The major metabolite is p-hydroxyphenobarbital, which is excreted as a glucuronide conjugate. PHB has extensive urinary resorption, which is enhanced by acidification of the urine. Metabolism of PHB is inhibited by phenytoin, PHT, valproate, VPA, felbamata, and dextropropoxyphene. Enzyme inducers such as rifampin decrease PHB levels. Because of the potent induction of the hepatic enzymes, PHB increases the metabolism of estrogen, steroids, warfarin, carbamazepine, CBZ, Diazepam, Clonazepam, and VPA. Its effect on PHT is unpredictable. In a multi-center double-blind study, PHB was found to be as effective as PHT and CBZ in the treatment of partial and secondarily generalized seizures. The Veterans Administration, VA, cooperative study, however, which compared PHB, primidone, PHT, and CBZ, showed a significantly lower retention in patients on PHB or primidone, despite their similar efficacy, because of poorer tolerability. No statistical difference was reported between PHT and CBZ. PHB is effective in a wide variety of seizures and is currently the cheaper AED. PHB still is a first-line drug for treatment of status epilepticus. However, because of its adverse effects, e.g., sedation and cognitive slowing, it is a second-line agent in the treatment of partial onset and secondarily generalized tonic-clonic seizures. In developing countries, it is used widely because of its low cost. PHB is available in tablets of 15 milligrams, 30 milligrams, 50 milligrams, 60 milligrams, and 100 milligrams, elixirs, 15 mg/ml, and injections, 200 mg/ml. The usual starting dose is 30 to 60 milligrams once a day. The dose can be titrated up to 240 mg/d. Slow titration is better tolerated. Therapeutic blood levels are 15, 40 mg/L. Physical dependence and withdrawal seizures occur with long-term use. Therefore, very slow withdrawal over several weeks to months is recommended. The most important adverse effects of PHB are cognitive and behavioral alterations. Children are more likely than adults to exhibit behavioral changes, e.g., paradoxical hyperkinesis. Sedation is prominent, particularly at the beginning of therapy, and usually subsides. Psychomotor slowing, poor concentration, depression, irritability, ataxia, and decreased libido are other effects. Long-term use of PHB may be associated with coarsening of facial features, osteomalacia, and Dupuytren contractures. Folate deficiency, megaloblastic anemia, and idiosyncratic skin reaction are rare. Vitamin supplementation is warranted. Hepatitis has been reported secondary to an immune-mediated process. 6. Primidone. Primidone is metabolized to PHB and phenylethylmalonamide, PEMA. Its main action is through the derived PHB. The real clinical effect of primidone or PEMA is unknown and controversial. Primidone is absorbed orally. Bioavailability is close to 100%, with a peak level after 3 hours. Plasma protein binding is only 25%. Elimination half-life is 18 hours, but that of the derived PHB is 120 hours. Primidone is metabolized by the cytochrome oxidase system, therefore it is affected by enzyme inducers, including PHB itself. The levels of primidone seldom are useful for monitoring efficacy and range from 5-12 mg/L. The PHB level is the same as the level when PHB is administered directly, 15-40 mg/L. Primidone has the same indications as PHB. It is available in tablets of 50 milligrams and 250 milligrams in suspension of 250 mg/5 ml. 250 milligrams of primidone is equivalent to 60 milligrams of PHB. The average therapeutic doses range from 500 to 1,500 milligrams. The major adverse effects of primidone are intense sedation, dizziness, and nausea at the onset of treatment, most likely secondary to administration of the parental drug. These effects usually clear after 1 week of treatment. A very low dose is recommended at the onset of treatment. Other effects are the same as those of PHB. Primidone can be used for partial onset and secondarily generalized seizures. However, it is a second-line agent because of its side effect profile, which is similar to that of PHB. It has been useful in the treatment of essential tremor at low doses. Gaba reuptake inhibitors. Reuptake of gamma-aminobutyric acid, Gaba, is facilitated by at least 4 specific GABA transporting compounds. These carry GABA from the synaptic space into neurons and glial cells where it is metabolized. Nipcotic acid and tiagabine, TGB, are inhibitors of these transporters. This inhibition makes increased amounts of GABA available in the synaptic cleft. GABA prolongs inhibitory postsynaptic potentials, IPSPs. Tiagabine, TGB, is a derivative of the GABA uptake inhibitor nipcotic acid. It acts by inhibition of the GABA transporter 1, JAT1. This inhibitory effect is reversible. TGB is lipid-soluble and thus is able to cross the blood-brain barrier. It was introduced into clinical practice in 1998. Measurements in human and experimental models have confirmed that extracellular GABA concentrations increase after administration of TGB. Studies have shown little or no effect at other receptor systems. The oral bioavailability of TGB is approximately 96%. The time to peak concentrations is approximately 1 hour after oral intake. A second peak of the plasma concentration of TGB is seen 12 hours after ingestion, probably caused by enterohepatic circulation. Food decreases absorption 2- or 3-fold. However, the total amount absorbed is unchanged by food administration. TGB's volume of distribution is 1 lkg, and the drug is bound extensively, 96%, to human plasma proteins. It is metabolized extensively in the liver by the P450 system. None of the TGB metabolites has any antiepileptic action, and less than 3% of the drug appears unchanged in the urine. The plasma half-life of TGB has been found to range from 4.5 to 8.1 hours in healthy volunteers, and this is reduced to 3.8, 4.9 hours in patients with epilepsy who are communicated with enzyme-inducing drugs. The clearance of TGB is greater in children. The elimination of the drug is reduced in patients with mild to moderately severe liver impairment. TGB causes a small decrease in valproate, VPA. It has no significant effects on plasma concentrations of progesterone, estradiol, follicle-stimulating hormone, or luteinizing hormone. Hepatic-inducing drugs increase the clearance of TGB by 2/3. TGB plasma concentrations are not affected by VPA, cimetidine, or erythromycin. TGB has been studied as adjunctive therapy in 5 double-blind, placebo-controlled studies, which demonstrated its efficacy. Besides these 5 studies, TGB has been the subject of other clinical trials designed to demonstrate efficacy, including 3 trials, 1 open and 2 double-blinded, in monotherapy and 6 open long-term studies. In a meta-analysis comparing these results with placebo-controlled, randomized trials of other drugs, no significant differences in efficacy were demonstrated among TGB, gabapentin, lamotrigine, LTG, topiramate, vigabatrin, VGB, and zonisamide, ZNS. In the long-term extension studies, 772 patients were treated with TGB, 80 mg/d, with reduction in seizure frequency by 50% or more in about 30 to 40% of patients treated for 3-6 months. This effect was maintained for 12 months in patients with partial seizures, but not in patients with secondarily generalized seizures. The drug is available for use as second-line add-on therapy in patients with partial or secondarily generalized seizures that are refractory to treatment. In the United States, the recommended dosage is 4 mg/d with a titration of 4-8 mg/d each week, and the usual maintenance dose is 32-56 mg/d. In Europe, the recommended dose is 15 mg/d, followed by weekly incremental increases of 5 to 15 milligrams up to a maximum of 15. 30 mg/d. In patients on concomitant enzyme inducers, the dose could be increased gradually to 45 mg/d. The most troublesome adverse effects of TGB include dizziness, asthenia, nervousness, tremor, depressed mood, and emotional lability. Diarrhea also is significantly more frequent among TGB-treated patients than placebo-treated patients. Other adverse effects include somnolence, headaches, abnormal thinking, abdominal pain, pharyngitis, ataxia, confusion, psychosis, and skin rash. No changes in biochemical or hematologic parameters are reported. Serious idiosyncratic adverse effects are recorded as commonly in patients on placebo as in those on TGB. A few clinical trials have reported the occurrence of convulsive and non-convulsive status epilepticus with TGB. In the author's experience, one case of non-convulsive status was caused by accidental overdose. TGB therapy should be used cautiously in patients with a history of status epilepticus. TGB is contraindicated in severe hepatic impairment, pregnancy, and lactation. Use of TGB is limited to adjunctive therapy in refractory partial epilepsy. It should not be used in absence epilepsy or in partial epilepsies with generalized spike wave, since it can worsen seizure control or cause status epilepticus. Gaba transaminase inhibitors. Gamma-aminobutyric acid, Gaba, is metabolized by transamination in the extracellular compartment by Gaba transaminase, Gaba-T. Inhibition of this enzymatic process leads to an increase in the extracellular concentration of Gaba. Vigabatrin inhibits the enzyme Gaba-T. Vigabatrin. In the 1970s, Gaba was recognized as an important inhibitory neurotransmitter in the central nervous system, CNS. Favoring the balance toward the Gaba system was a major target of drug research, and soon Vigabatrin, VGB, was developed. The U.S. Food and Drug Administration approved VGB in 2009. Although effective, it can cause vision loss, and because of this risk, it is not used as a first-line agent and is available only through a restricted access program. VGB is indicated as adjunctive therapy for adults and pediatric patients aged 2 years or older with refractory complex partial seizures who have inadequately responded to several alternative treatments and for whom the potential benefits outweigh the risk of vision loss. Additionally, it is indicated as monotherapy for infantile spasms in pediatric patients aged 1 month to 2 years for whom the potential benefits outweigh the potential risk of vision loss. VGB is a close structural analog of GABA, binding irreversibly to the active site of GABA-T. Newly synthesized enzymes take 4 to 6 days to normalize the enzymatic activity. In vivo studies in human and animal subjects have shown that VGB significantly increases extracellular GABA concentrations in the brain. VGB has no other known action. VGB is highly soluble in water but only slightly soluble in ethanol. It is absorbed rapidly after oral ingestion with an oral bioavailability of 100%. Time to peak concentration is approximately 2 hours, and the volume of distribution of the drug is 0.8 L-kilowol. About 10% of the plasma concentration is found in cerebrospinal fluid, CSF. Only a small fraction crosses the placenta. VGB is excreted in urine up to 95%, with a half-life of 4 to 7 hours. In elderly patients, clearance is reduced and the half-life may double. VGB does not induce the activity of hepatic enzymes. Correlation between plasma levels and clinical effect is poor. VGB can reduce the plasma concentration of phenytoin, PHT, by 25%. This reduction probably is mediated by decreased absorption. However, the exact mechanism is unknown. No other pharmacokinetic or pharmacodynamic interactions are present. VGB has been studied exhaustively in 9 double-blind controlled trials. These trials reported that 40 to 50% patients with refractory partial seizures had a reduction in seizure frequency of more than 50%, and as many as 10% of patients became seizure-free. Many patients continued the drug after completion of the trial. The dose of VGB ranged from 1,000 to 4,000 mg/d. VGB is less effective against primarily generalized tonic-clonic seizures, and also may worsen myoclonic seizures or generalized absence seizures. Like tiagabinum, TGB, VGB has been reported to cause absence status. Patients with myoclonus or Lennox-Gastaut syndrome do not respond well to VGB. In placebo-controlled trials in patients with refractory epilepsy, 20% of children and 5% of adults showed an increase in seizures. VGB is very effective in the treatment of infantile spasms. Therefore, it is the drug of choice for this indication in many countries. The usual starting dose for adults is 500 milligrams twice daily, and this is increased by 250 to 500 milligrams every 2 weeks to a maximum dose of 4,000 mgd. In children, 40 mg/kg/d is the usual starting dose, with maintenance doses of 80 to 100 milligrams per kilogram. The most common adverse effect of VGB is drowsiness. Other important adverse effects include neuropsychiatric symptoms, such as depression, 5%, agitation, 7%, confusion, and rarely psychosis. Minor adverse effects, usually occurring at the onset of therapy, include fatigue, headache, dizziness, increase in weight, tremor, double vision, and abnormal vision. VGB has little effect on cognitive function. Acute hypersensitivity and idiosyncratic immunologic adverse effects are extremely rare. VGB causes widespread intramyelinic vacuolization throughout the brains of rats and dogs. However, primate and human studies have not demonstrated such changes. VGB also affects the retina in some rodent species, and later human studies show visual field changes, characterized by nasal constriction and then concentric constriction, with preservation of central vision. In one series, visual field disturbances were found in more than 50% of cases. The mechanism of this effect is unknown, and the risk factors are unclear.